And what I said to John McDonough after a 45-minute meeting with him is, look, you guys are breathing this rarefied air about how you're financing this. I mean, that's beyond my pay grade, all right? I'm not there. Plus, you don't really care what I think anyway. You're listening to the health insurers. You're listening to Big Pharma. You're listening to hospitals. You're not going to listen to me. When y'all get done, the dust gets settled, and we know how much money is on the table, I'm going to tell you how to spend it. That's what clinicians know. We know why you can't bend that curve. You talk about the cost, healthcare going up. You hear the phrase, we're trying to bend the curve. Bring that down. Well, how do you bring it down? You do things differently. Well, who knows how to do that? Clinicians. Think about it when you're in your clinical settings. Who are the people that are coming in? How did they get there? What services are we providing? Are we providing those in an efficient way? One of the biggest reasons that people come back into the hospital is because they got poor discharge planning. You know what happened at discharge? Nobody reconciled the drugs they were leaving the hospital on with the ones they have at home. And they have an adverse reaction at home and come back. Hello? Isn't that nursing? I talk to my senior nursing students, you know what they tell me? We don't have time to do discharge planning. Really? Did you have time to give them their drugs? Oh yeah. Why didn't you do discharge planning? Well, there's not enough time. Sure there is. That's a nursing intervention. You don't let them go home till you do it. It has to have that same level of importance. You keep them from having to come back into the hospital, which is a very good thing. Having an 87-year-old father, I don't want him going in A, and I certainly don't want him going back in. And I'm totally dependent on nursing to do that. You say about a hospital admission, the big area in legislation right now is how to prevent readmissions. They have big penalties. They're going to start charging hospitals for patients that are being readmitted. You're in the catbird seat to figure out how to do that. No one's talking about delivery system reform. It is absolutely more important than any of the other conversations that are going on. That's where y'all can play a huge role. And a lot of what I'm doing is looking at the legislation that is there and offering people on the Hill and in the White House and elsewhere, where are the places that you should be strengthening these bills to really make a difference in how we're going to deliver care? We don't change that, we're toast. I don't care what the CBO says. We're toast if we don't do things differently. We must. Plus, the way we're doing them now isn't good. Yeah.
And when you talk about discharge planning, to me that's really prevention.
Totally.
And that's one of the big things. You hear the word every once in a while comes out, but it's almost like nobody wants to tell other people, because we have this, to me, it's the society of, I want to do what I want to do, and...
Yeah, you know what? That's over. I mean, can people grow up? I mean, come on, we're all about this. I want something uniquely American, uniquely stupid, yes.
I feel like there's so many things like prevention, like discharge planning, so many ways of making the system better, but for doctors, hospitals, people that are really in it more for the money, possibly,
yes.
They're purposely preventing those from
That's exactly
happening.
Right.
So do you think there's something that's going to happen in healthcare?
Yeah, we're going to get out of it
right
big
now?
time. Everything is on the table. Right now, we are looking at hospital readmissions. Steve Jenks, an old friend of mine, who has worked at the Center for Medicare and Medicaid Services, had a big study that was published earlier this year in the New England Journal of Medicine. He and I think Eric Coleman was on, a couple of other people were on it, in which what he showed how many people come back into the hospital within 30 days of being discharged. This is Medicare, right? But they're the ones more likely to be hospitalized. How many of them come back in within 30 days? And these are not planned readmissions. Between the day that they were discharged and when they came back in, they did not see a physician. So it's not as if they went to the doctor and the doctor says you need to be readmitted. Right? They went back in without seeing anyone else, which means something happened. Right? Most of those are preventable. Added up what the cost of those are. Now, hospitals make money when a bed is filled. Right? They don't care about readmissions. I mean, it's not that they're inhuman. They've got a completely different objective than we do. And if I'm a payer, I don't want them to be, as a child of a parent, I don't want them going in either. So I have a very different objective than they do. Right? So the question then becomes, all right, since they don't care, and let's be honest, they run what goes on, how do you get them to change? Right? You have to give them a carrot. Right? So if Medicare saves money on that, can we share the savings? So Medicare saves money. You give that then back to the hospital to establish programs to keep more people out of the hospital. So recognizing that, or change the way we pay hospitals so that they have an incentive not only to keep people out of the hospital, but can they take that money and roll it into other service? Are there other lines of service, like building, using right here at Penn, Mary Naylor's model on transitional care? Can they build a line of business called transitional care that provides services in the home subsequent to being discharged, coordinates that care across the entire episode? By the way, that's one of the pieces of legislation that I worked on, was getting that written into a bill. Follow that. It's nurse-led model. It's an established, innovative practice, American Academy of Nursing. Everybody gets it. Like, well, yeah, if you follow somebody and monitor them from the time that they're in the hospital to 90 days out, you probably stand a pretty good chance. So a hospital could establish that as a line of business. Why not? They're entrepreneurs. We need to be thinking about how to do that. Physicians have an incentive to see more people in the hospital to get an extra payment. Right? You're going to have to change the payment incentives. So they're like, I don't want to see Medicare patients. Fine. Stop. They won't. It's a scare tactic. Yeah.
Do you think that we're on the right path to doing that? Because I think every article I read is like AMA, like protesting this, like lobbyists for hospitals.
Yeah.
And,
it's with the airwaves versus what's really going on. So the AMA is, the AMA, and actually it's very interesting. They have come out and they have endorsed health reform. Yeah, and not they did because they got a few things fixed. It's the tide is shifting. We have what's happening now in health reform, which is very different from 15 years ago when I was doing this under Hillary Care, whatever they want to call that thing, is the internet. Huge. The opportunity, everybody's blogging, all right? Everybody's tweeting and twitting and all of it. The lines of communication are so broad that the dominant forces who, with their money and with their lobbyists, had more of an opportunity to influence the process, no longer have that because communication has been democratized. We now have more opportunity. What was very interesting, and as an example, some of the legislation on the reform, on the delivery system side, is looking at expanding primary care, both payment for primary care, organizations, starting new organizations to deliver primary care, coordinating primary care differently, all of that. So who does that? Well, practitioners, you have physicians. Well, physicians have said primary care is physician care, and then everybody else gets delegated simply because they said it first. I mean, there's no divine, it's not in the 10 Commandments or something. So it's just they said it's there. And a lot of states still have restrictions on the scope of practice of nurse practitioners to be able to fully independently practice primary care. So in these bills, the various nurse practitioner organizations have been working very hard to try to insert language that allow them to do this. And the physicians have been saying, no, they can't possibly do this. Well, the staff of these committees have gone back to the physicians and said, wait a minute, we have 20 states that have practice acts that allow nurse practitioners to independently practice. So how are you saying you have to direct them? You can't say that in federal legislation because that upends the state constitution and state regulatory framework. States already allow them to do it. Who do you think you are? They can do it. How is it? What do you mean? So they're like, oh, and they kind of backed out the door.